Well, good morning or good afternoon, depending what part of the country you all are calling in from. My name is Alan Miller, and it's a pleasure to welcome you today to our webinar from our team here at Cope Health Solutions. We're going to talk to you all today about how to manage a growing Medicaid population with an FQHC strategy. And we're very excited to be able to share some of the information with you all. We've got a great group of experts. So Dr. Andy Snyder is our Chief Medical Officer and a principal in our firm. Andy has really a deep breadth of experience across the country, developing clinical strategy, both at the health system and also the IPA and independent physician level. He's been an executive running clinical integrated networks for Mount Sinai Health System, built their clinically integrated network of about 3,500 doctors. Was also Chief Medical Officer for Brown & Tolan, which is a large IPA in Northern California. And with our firm and other places he's been a key leader and a key expert helping people think through all lines of business strategies. And of course, today, as with many of us, he's spending a lot of time with folks on their Medicaid strategy as that line of business begins to grow. Elizabeth DuBois is a doctorally trained family nurse practitioner, one of our vice presidents in the firm, and another one of our principals who tends to lead accounts across the country. And Elizabeth has a very deep experience both in health systems and inside FQHCs as an executive leader, dealing with everything from clinical operations, care redesign, care coordination, strategy, physician alignment, and population health. And Elizabeth served prior to coming here. She was the Deputy Chief Medical Officer at the largest community health center in New York City, Community Health Network. And again, prior to that, also had executive roles in health systems. And we're really pleased to have Elizabeth here for this webinar. And Sarin Khachatourians. Sarin has agreed to stand in for Kathy Walker, who works with us regularly as one of our FQHC experts on the team. Sarin is one of our senior managers who has done a lot of work across the country, managing accounts and bringing to bear her expertise specifically to help health systems and specialty organizations to develop FQHC lookalikes and improve their FQHC partnerships. So we've got a great team, and we're really excited to be able to share with you some of what we've learned. So a little bit of housekeeping. There's a Q&A function in Zoom. And you can answer or ask your questions through there, and we'll be happy to either answer them at the end. If we don't get to your question, whether you enter it in Zoom or send it by email to info@copehealthsolutions.com, we will get all questions answered because we'll actually send out along with a PDF of this webinar, the PowerPoint deck, a tape of the webinar. We'll also send you a copy of written Q&A from all the questions asked, both before the webinar and during and after. We'll also have a brief survey go out after the webinar. We'd really appreciate if you get a chance to answer that. If we have time toward the end, we'll do live Q&A. If we don't, again, we'll get the written Q&A out to folks. So our agenda today, we'll talk briefly about an overview of what's happening in the environment, not just the COVID crisis, but just generally what's happening with Medicaid right now. It doesn't bear repeating or need to be said that the COVID emergency is unparalleled in our history and is creating massive challenges across the board. Today, our focus is on Medicaid strategies and particularly how to bring FQHCs to bear. There is a lot of COVID impact there as well. We'll talk about some of the specific value propositions for health systems and IPAs, by the way, and medical groups, who often have not necessarily thought of FQHCs as a key part of their networks. And many times historically, health systems, IPAs and others have been focused more on the commercial and Medicare lines of business. Medicaid for some folks has not necessarily been a core line of business consideration. That has been changing over the years as many folks have realized that Medicaid managed care is an important business to be in, as folks have looked at all lines of business across their systems. But today it's becoming important, again, as we'll talk about, because the Medicaid population coming out of the COVID epidemic is going to grow substantially, and we don't believe it's going to snap back anytime soon. We'll also talk about value propositions for the FQHCs. So there's a value on both sides when folks collaborate, and the community FQHCs are absolutely critical for the health systems, and the health systems and IPAs are important for the FQs as well. We'll give you an example of a process of if you are a health system, an IPA, or a medical group, and you have a high volume Medicaid clinic and you're thinking about transitioning it to Look-Alike, Sarin will talk you through that process. And finally, we'll have some time for Q&A. So it should be a fun hour, and we'll look forward to it. So let's go to the next slide and kick it off. So let's talk about what's happening in the market. COVID is not everything that's happening, but it's clearly a major, major driver. It really, I would ask folks to think about, in this context, COVID is really shining a light on what was already an inherent value of FQHCs, but it's really making it much more obvious where FQHCs should be brought to bear as partners, and why an FQHC strategy is so important. We're working on access to care, maximizing revenue, and reducing costs. And if you break into those a little bit, one of the things to think about, Kaiser Foundation recently came out with some survey information, actually, I think today. They talked about the fact that almost 50% of all US people in the US are saying that they have been putting off care and expect to go back and get care in the next few months. When you partner that up with the fact that in California alone, it's projected that 2.5 million people, and this is based on numbers that are almost a few weeks old now, 2.5 million people will be eligible for Medicaid in 2021 in California alone. So what's happening is we've got these parallel challenges of Medicaid, uninsured, and subsidized exchange populations growing really, really quickly. At the same time, we've got reduced commercial coverage, and we've got a whole bunch of people who haven't been accessing care who are going to come back in and start to access care. The FQHCs are going to be critical partners in being able to provide that access, not only in the next 6 months to a year, but going forward, we believe they're going to play a much more critical role. So we've got some numbers on here. You can see 27 million people nationally. Just numbers that are a little bit mind-boggling to imagine that people are starting to think about now. What does that mean for this my community? And then finally, there also are regulatory changes. It's easier to do telehealth and to bill that through an FQHC. Some of the rules of the road around how health systems and IPAs could partner with an FQ around specialists and other types of opportunities to leverage telehealth with a partner are becoming easier because of the regulatory relief. It's also easier to clinically integrate generally, as Andy's going to explain. And the financial incentives are becoming more aligned with the health plans beginning to realize that value-based payment is the way of the future. So when you think about, as a health system or an IPA, how to partner with an FQHC, or conversely, if you're an FQHC and you're thinking about how the health system partnership might work, we think of it in 3 major buckets. First of all, health systems and IPAs may have clinics, existing clinics, that have very high Medicaid that are a good fit in different ways, and Sarin will talk about that a bit more later, to be considered to become an FQHC, either a look-alike or to partner with an FQHC in the community so that they, through a change of scope, take on that clinic. And this is a deep partnership, of course, then between the health system and the FQHC. The third area is just integrating FQHCs generally into your value-based payment and your clinical integration strategy, which is one of the things we've seen some folks do very well. There are some great examples in certain communities across the country, and other communities where FQHCs have more often been seen as a little bit different. Those are the folks we give community benefit dollars to. They might be helping us to decant our ER, but they're not necessarily a partner. And that's where we're working to get folks to think about today is how do you actually bring an FQHC into your network as a partner and really leverage their capabilities alongside yours. We'll kick it off to Andy. Andy, do you mind talking a bit about the FQHC kind of key considerations for alignment, and then we'll kick into the clinical integration piece?
Sure, happy to. So thank you everyone for joining, and thanks for the introduction, Alan. Talking about how FQHCs can align with health systems, and we're going to talk about why it's important for health systems to do such a thing. One of them is just sort of the control over the consistency of graduate medical education. So FQs can play an important role in training our residents and training future doctors and other ancillary providers. As teaching clinics, some systems choose to want to keep that in-house, some want to partner. That is one of the strategic questions we deal with our clients, but it's a big added benefit when you're trying to balance resources, your network of physicians that you employ, your specialists, and the amount of volume that you need to churn through your clinics. Obviously, as Alan was just speaking to, there's a huge increase in the Medicaid and uninsured populations, which we'll come back to again and again, unfortunately. The marketplace and the politics matter, right? So who's already in your market for other FQs, for other potential partners in this space, and will it spoil relations with others? So just like we deal with health plan politics and relationships, there's similar relationships across the community. There is an access to enhanced federal reimbursement through the PPS rate at FQHCs, so we want to talk about accessing that and where that can be beneficial. And the governance versus independence of the FQ and of the systems and the programs within. So I want to talk to you more about the sort of the value to health systems. Why should health systems need an FQHC strategy? Well, first and foremost, there's an aligned mission, right? Providing access for the underserved. I've worked in multiple large systems and I work with multiple systems now. All of them are keenly interested in helping the underserved. It's interesting that the lack of relationships with FQHCs providing the expertise that they have, I just find it interesting that they're not already partners. But as we were saying, with this changing demographic that's just sort of hit upon us, it's becoming more and more poignant. These partnerships need to happen. It's needed for clinical continuity, and systems are just going to be sharing more and more patients with FQHCs going forward for the time being, at least. The other is primary care access. We're going to come back to that as well and why that's helpful to the system. But certainly increasing access to primary care in any setting across provider types is important these days. There's also the improving communication, coordination, data exchange with the FQHCs improves the care. And it's a better network and provides and makes you as a system or hospital a better partner for your managed Medicaid plans. I think one of the biggest reasons is that FQHCs have some really specific expertise that systems tend to struggle with. Besides that they integrate behavioral health, they integrate pharmacy services a little more than generally done at systems. They also excel at enabling services. Those enabling services consist of things like care management, referral management, but they also consist of translation and interpretation services, eligibility assistance, health education, health literacy, environmental health risk assessments, outreach, and transportation. Those are obviously really important links in the continuum of care. And with that, it's pretty easy to understand how that can address and affect positively quality of care. And when you're improving the quality of care of your population, now you can start aligning those financial incentives, because it all starts with quality of care, with the FQ, with the system, and then with payers alike. Let's go to the next slide, please. So as you're working on those and engaging them in their enabling services and improving quality, that is sort of a beginning of a clinical integration framework, and we're going to come back to that. But through a clinical integration or similar network structure, you can coordinate and strengthen the quality, as we just talked about, and the utilization management for mutual success in value-based contracts. And I think that's a key here. Coordination of care for the underserved populations can directly reduce avoidable ED visits and other unnecessary and duplicative services and utilization. One example is like patient navigators in the ED. It's needed, most are doing it, but the FQs have navigators often in the ED, so do the systems, so do IPAs. There's a lot of inefficiency trying to achieve the same outcomes and the same purpose. So partnership there at the programmatic level, of course, is really what it's all about. Also, there's an increase in specialty care and specialty access. Obviously, that's a big thing that FQHCs are looking for from health systems. But in reverse, I want to say that it's a strategy that we're seeing with clients that you can, if you're looking to increase a department size, increase your teaching force, or other niche areas of specialties, you can share those FTEs with FQs and increase your department without all the costs because they will be able to take on part of that FTE. Those providers can access the PPS rate, so it's not a loss. And importantly, they can access the Federal Tort Claims Act, the FTC med-mal coverage for all the patients seen at the FQHC. And when you're speaking of high-risk OB and other services, that's a pretty significant piece of baggage there. I would add, just before we leave this slide, that a couple other benefits to the system would include things like FQHCs are uniquely excellent at helping complete and implement community health needs assessments. And again, I just want to reiterate the teaching component that they can provide in a primary care space, especially. So I mentioned about clinical integration, and now I want to speak to it in the broad sense of clinical integration. There are clinically integrated networks with an FTC regulation over that, and we can speak to that as well. And we work with clients on that. But clinical integration is a continuum. That is one of the endpoints, but everyone has a starting point. And I think, and we're seeing across the nation, it's very different for everyone, but it's universally sort of the path that people are on. And this slide is to represent the fact that we have to start thinking of our delivery system in a much broader way. We're used to thinking of it as our hospitals, our employed physicians, and our IPAs. Some are beginning to work with more community physicians, but now we really have to start thinking of these FQHCs as a primary hub of contact for many, many patients of ours. And again, their expertise and their ability to access community-based organizations that systems tend to struggle with again. So I think we have to start thinking of clinical integration in a much broader sense, not just at the physician level, but across the facility level as well. And I think that's a strategy that many are beginning to think about very seriously. So how would it fit into, again, a broad sense clinical integration strategy? Well, you want to integrate your care models, and that's one of the benefits you get. You start working with a broader base of physicians, a broader population of patients, and you start standardizing the clinical pathways. You start standardizing and collaborating on the analytics and how to identify the right patients in need, who and how to outreach, what kind of surveillance is done, what kind of disease management is done, access and wraparound services, so you can start getting efficiencies of scale and standardize these programs. And a big one of that would be the next bullet there is telehealth. So telehealth obviously is going to be changing within our care model going forward. And I think that's been very evident now with the COVID crisis. And B, it should be reminded that for a long time now, FQs have been able to access or have other funding sources for some telehealth implementation services. Some that have taken advantage of that, there are FQHCs out there that are quite advanced in this technology, and many systems are not. This is something that they might be able to help you back with as a system. So another thing to keep in mind, if your FQHCs do have that expertise. The next piece is to increase access for your value-based patients to those enabling services for the social determinants of health. Right? Most systems struggle with a social work department that does a lot, what it can, a lot of times within the four walls, but it's very hard getting out into the community from your employed department quite often. So this is a way of getting help with that and getting access to those CBOs and knowing who to refer to when and how to access them in a much more streamlined fashion. Finally, we mentioned quality. Well, aligning the strategies around quality, so it's not just improving quality in general because yes, they access those enabling services and get some better wraparound care, but you can actually align strategies, align programs and resources across that broader community. And again, get efficiencies and it makes a bigger case towards the payers universally when you're clinically integrating and working towards a common goal. And you get a bigger bang across the community than each group trying to solve its own quality issue or work on different metrics selectively. And then the last big one that's a real big actual benefit to systems is sharing that risk, but increasing your primary care attribution in your value-based contracts. As we know, going forward, the new metric is covered lives, is populations, attribution. So within your ACOs and across your value-based contracts, you can increase your attribution. And by doing so, as you enter into the savings side of the equation, it's a rising tide floats all boats principle. So you need more attribution. That is what keeps you float in the value-based contracts. And again, within your network, it also provides downstream revenue at the top line to your facilities as well, because those patients do need services inpatient as well. So, on that, I want to, the last adage I would think about is what's really important here is, it's been said many times, stronger partnerships gives you stronger communities. And I think that's what this is all about. And on that note, I'm going to hand it over to Dr. Elizabeth DuBois.
Thank you, Dr. Snyder, and a great point to end it with as I get into this next section. So as I talk about what the value is for FQs, it's also really important for the health systems and the IPAs and medical groups to understand what value the FQs are looking for or in need of, because that is going to help you as a health system really start thinking about the partnership you're creating or the integration as you move forward in this process with the FQs in some manner. And so just first collaborating with the providers across the community. And so as the FQs work together with the medical groups, the hospitals, the health systems, the IPAs to really jointly manage the same community, as Dr. Snyder was just referencing, there's a lot of things to think about within this. So first, you think about efficiently utilizing and sharing the resources. Well, first, obviously, this comes to community-based organizations. How can the partners, whether it's the FQ and the health system, or as you're aligning with the FQs in some manner, really think about efficiently maximizing the utilization of the CBOs to really help serve the community in the best way possible. Also thinking about the care management services that Dr. Snyder was just discussing. This is the bread and butter of FQs, and knowing how to, put in the community health worker, the patient navigator, set up the medical home, really engage with a more complex population in terms of significantly high social barriers that complicate the care picture and make the population a difficult to engage and sometimes retain population. And so how are you maximizing the utilization of the care management resources and not having to double up? And then thinking about your ancillary services and your specialists, and again, maximizing the efficiency with them and where you're able to create these partnerships that allow for, the maximum increase in access that you can get with both of these partners. And that's ultimately going to lead to the better engagement with patients and then, of course, their families and caregivers. Creating this better patient experience is going to continue to increase the access that you're able to provide and really allow for the retention of care with your patients, which is so critical with this as well, especially as you're trying to decrease some of these social barriers to move forward with quality outcomes. Also want to reference here just steering to appropriate facilities. We obviously know there's patients that need to be with a PCP that sometimes end up in the ED, and there's patients that end up in the ED that would be better served in the outpatient with a PCP. And so when you're creating these partnerships and you're collaborating across the line, you're able to better steer patients to the appropriate facilities. When you think about the FQ's experience and creating the education and the materials, the translation services, the different opportunities to engage the patients in order to retain them in care, keep them with their PCP versus going to the ED to access services, it's also going to be a great opportunity for the health systems to utilize those same resources and have that same strategy to also be able to, steer the patients to the appropriate facilities, whether it be for the PCP versus ED. And so it's a great opportunity to really collaborate here to make sure the patients are getting to the right service at the right time, which will ultimately improve just your overall efficiency, cost, and quality. And then utilizing the patient navigators and virtual technology. And so, we talked about the patient navigators, Dr. Snyder mentioned it. It's just, the clients that we have consistently worked with, these health systems, these ACOs that partner with FQs, have the embedded care management services are able to implement care management programs at quicker time frames and able to really have quality services with these, maximizing the utilization of the staff, the labor, and then the outcomes associated with patients, just due to the comfort they have with this sometimes more complex population in terms of social barriers. And so it's the opportune time to think about that right now, especially knowing that, these increase in patient populations with Medicaid are going to have just as consistent, just as similar social barriers, if not more, as they're navigating this, the current time. And then again, with the virtual technology, your FQs have had to partner to do telemedicine with the specialists to create these increase in services when there is often no other opportunities to do this. And so there's already an ability to engage with their patients to be able to provide these services. And so partnering together to think about, what knowledge you can take to apply to your current facility is going to really enable you to move forward and not having to reinvent the wheel and go through additional time as we're trying to move forward. And then finally, integrating into the care model to ensure a balanced payer mix. And so you have to think about both, both types of facilities are coming into this thinking, they want to make sure that there's a well-balanced payer mix so that, they can appropriately give the right services and access to patients and have some financial revenue coming in that ensures they can continue this. And so making sure that there's collaboration is going to allow the well-balanced distribution between the uninsured and the Medicaid amongst the organizations. And that's, you have to think about the FQ's perspective is going to be thinking they want to make sure that they're not, very one-sided and they're getting this well-balanced mix. And so as the health systems are trying to partner with them, it's important to understand how you can sit together to make sure there's this well-balanced payer mix across the board. So as you talk about strengthening the partnerships, having this collaborative strategy to ensure there's alignment in your services. And, Dr. Snyder said, we have one mission. We're all coming with the same purpose. We want to have this access for the community. We want to create better quality care and services. But how can we do it together? How can we make sure we have this collaboration? And so this is a great time to collaboratively approach the payers together. Approach the payers with the FQs from the healthcare systems. Approach them, to talk about what additional funds can be pulled down to better care for this population. So additional funds to pull down to leverage the CBOs to help reduce some of these social barriers, whether it's transportation or food or, housing. What can be leveraged within the current population you're serving within the community? That is going to excite, the payers and the managed Medicaid as they're thinking about the quality outcomes they'll see with this increase in services. Ultimately, of course, there's increase in services and access because as we're creating these partnerships, as we're going to the payer and we're saying we have these partnerships, we can do the inpatient, we can do the outpatient, we have these specialty services, we are ultimately increasing the access, and we're going to avoid losing patients to, the follow-up care they need or the higher level care they need to the specialist. And so it's really allowing for that retention and service and then ultimately creating the better access. Improving the patient experience, as we leverage the CBOs and we're supporting with the social barriers, you're ultimately improving the experience for the patient and you're engaging them in their care, which, yes, is great. It's going to get the quality outcomes and get the financial revenue associated with that. You also, we think about the clients we worked with the ACA changes. And when that happened and there was a flux between the uninsured to the insured, there was, those that had strong alliance to their PCP were retained in care despite the flux of payers. And so, you want to think about that now because whether these patients have a flux in Medicaid to whatever down the road, you want to ultimately retain these patients in care. And so it's important to think about their patient experience, not only right now, but long term. Increasing the enabling services, and so a lot of the things that we've been talking about as far as being able to provide these additional ancillary services or specialty services that might be needed and retaining them in care, but also thinking about, you know, your ability to, if you have a cardiologist that you embed in an FQ, the cardiologist patients can now have a PCP or a medical home, and you can think about, you know, what services that the specialist patients population may need, that embedding in the FQ or partnering with FQ is going to really help care for the population better. And of course, the FQ is thinking about what services or gaps do we have within our population that can be better cared for if we embed the specialist, if we have a cardiologist, if we have an OB to do the prenatal care, if we have a GI, and so a GI specialist. And so, you know, both hugely beneficial to the population and then both of the facilities. And so just kind of looking ahead at what services are going to best serve the population from a collaborative perspective. And then managing the increase in patient volumes. And so as you're thinking about, you know, increasing the volume right now to care for the patients, either from the FQ perspective or from the health system, these additional services are going to help manage the population so that you can add on more and more to be taken care of. And while we're, you know, wanting to make sure that we're not only adding on the patients and increasing our population sizes, but we're doing so in a meaningful and deliberate way that will safely take care of them and retain them. You know, lastly, I just want to talk a little bit more specifically about the increasing in the access. And so from the specialty care and, you know, embedding these specialists within the FQ or partnering with them. And so there's a more strategic collaborative relationship between the health system, you know, can be incredibly beneficial for the patients, but also the provider, and that they're able to care for their patient more from a whole system perspective and a way where they're able to have data in real time versus trying to get the data, you know, from 2 weeks or 3 weeks or a month ago, or heaven forbid, even longer than that. And so really allowing a more user-friendly from the provider perspective to care for this population is a great benefit as well. And, you know, thinking about the specialists receiving some percentage of the PPS rate. So if you're embedding the specialist into the FQ, working out a relationship, an agreement where there's some sort of percentage of the PPS rate, as Dr. Snyder alluded to, can be much more than the traditional office rate of a Medicaid visit. And then thinking about, too, the inpatient care that can be done at the hospital that's partnered with the FQ. And so what population is this FQ taking care of, and where are their patients going for the inpatient services they need, or for the surgeries that they need, the elective surgeries that they need. And so, you know, there could be a benefit from the partnership and not only the care that the specialist can do in the outpatient setting, but also where those patients are then going to get their inpatient care. And allowing this partnership in the outpatient setting is really pipelining for what can be done in the inpatient setting. Ultimately, too, again, increasing your operability, increasing your user-friendliness for the provider, and ultimately creating the better quality care for your patients in the community. And then with your ancillary care, what abilities or what opportunities are there to partner to think about some of your ancillary services? So your radiology, your x-ray, your ultrasound machine, your laboratory facilities, if not already within an FQ, or potentially the increased or higher services that may be needed that you know, a typical or standard lab in an FQ may not have, that the partnership could allow to better serve the patient. And so there's a great opportunity right now with the CARES funding. There was specific funding that was associated with getting access to this equipment, purchasing this equipment, leasing this equipment to be able to provide services. And so thinking what opportunities are there to put this equipment with potentially a specialist or a staff individual within an FQ that is going to ultimately serve the FQ patients better, but also, you know, thinking about where these patients will then go for their additional specialty services or inpatient care or surgery that they may need. And so, you think about from an FQ, you can't right now have this one-stop shop and that everything can be done the same day just due to the PPS payer rates, and you can't have, the specialist and the PCP and the podiatrist all see the patient the same day and all get the PPS rate. But you can provide a one-stop shop or facility in terms of, if they go see their specialist for their cardiology care, then they can also see their PCP at the same facility on a different day. And everything is very easy to read, same EMR, and the patient has one medical home they're going to for their services. And then feels connected when the specialist wants to see the patient in the hospital as well for their elective surgery or whatever the service may need. And so being able to add more billable services by providing this on-site care is really important right now when you're thinking about your overall, not only short-term but long-term strategy in caring for the population, retaining the population, better quality care, and increasing the population size too. Okay, I'm gonna hand it over to Sarin now.
Thanks, Elizabeth. And so as we mentioned at the start of this webinar, there are 3 big bucket options when considering an FQHC strategy, and one of those 3 options is transitioning the high percentage Medicaid clinics into an FQHC Look-Alike. And so in this last section, we'll talk through that approach and process we typically take when we're standing up an FQHC Look-Alike with our health system and IPA clients. So we wanted to start by answering what are the key differences between an FQHC and an FQHC Look-Alike. And as we can see on this slide, there aren't too many. In this first item, we can see that FQHC Look-Alikes are not eligible to receive the 330 grant funding. There isn't always the opportunity to receive that grant funding to go along with the FQHC status. And in many cases, we can bypass that funding, which is typically around $650,000 annually, and instead move towards receiving the FQHC Look-Alike status, which still operates very similarly and has access to most of the benefits that a fully funded FQHC would have. FQHC Look-Alikes are also not eligible for the FCCA Federal Tort Claims Act malpractice coverage. And the last difference here is that FQHC Look-Alikes are not eligible for the federal loan guarantees for capital improvements. Other than that, we can quickly see that FQHC Look-Alikes don't receive access. Though they don't receive access to malpractice coverage in a 330 grant, there are still a lot of benefits. And so they're eligible to receive the enhanced Medicare and Medicaid reimbursement, and that's really the key here. It provides the FQHC Look-Alike with the opportunity to leverage that enhanced reimbursement so that they can invest back in the community, grow their services, wrap those services with some much needed enabling services such as interpretation, care management, transportation, health education, that this patient population so desperately needs to be successful in managing their health care. It also allows access to the 340B drug pricing program, which not only benefits the patients, but also offers another revenue stream to the FQHC Look-Alike. And finally, as a health professional shortage area, HPSA, FQHC Look-Alikes are eligible to apply and receive J1 visas, which ends up being an incredible provider recruitment and retention tool. So I'm not going to spend too much time here, but as we consider the strategy, one of the first things needed to be done is to determine the eligibility based on the following criteria on this slide, and I'll just talk through a couple of these. The first item here is organization type, and so typically nonprofit or public if it's a county or government agency with a clinic. Secondly, the FQHC Look-Alike cannot be owned, controlled, or operated by another entity. So this means that the organization has to be willing to spin off the clinics into an independent standalone organization. We realize that this may cause pause, but this is an area we spend a lot of time helping our clients navigate through, which starts typically by strategically aligning the new FQHC Look-Alike with the IPA or health system. And the last item I'll mention here is that the FQHC Look-Alike must provide core primary care services for at least 40 hours a week. And obviously there are many details here that are critical, and as we work through this checklist and are able to mark all the boxes, we can then say we're ready to move forward in this transition process, which we'll talk through in just a second. So what does the overall transition process look like? Based on our experience, we typically start by assessing the clinics, and so that could be both outpatient or hospital-based, and we evaluate their readiness for the FQHC Look-Alike transition. Next, we can plan and prepare for that transition process, which will start with becoming an independent standalone entity with its own governing board. HRSA has actually recently seen this FQHC Look-Alike transition process becoming more of a national trend. And so they have begun to reinforce becoming a standalone independent entity first before the organization can begin their 6-month compliance period. And so we realize that this, of course, is an important consideration to take into account during the planning process as we think through the operational and business configuration requirements. Once that's done, you can begin your 6-month compliance period where you act like an FQHC Look-Alike, which includes having the full board in place and also abiding by a few operational policy requirements such as the sliding fee scale, and that's the FQHC Financial Assistance Program for those who are not familiar. Next, we can submit the application, and HRSA will review that application and conduct a site visit. And upon receiving approval, we can begin our year 1 rate setting year. And on the next slide, we can see an example timeline of this process we just outlined. Okay, so the assessment process typically takes about 3 months, but of course this depends on a number of factors, including the number of the clinics that are in question. Once that's done, we typically take around 6 months to plan and prepare to become that standalone entity. And then after that, we can begin our 6-month compliance period. During the same time, we prepare the application so that we can submit at the end of that 6-month period. And then HRSA typically takes around 2 to 3 months to review that application process and complete their site visit. And assuming we receive designation after we submit our application, the whole process generally takes 21 months. And this is a pretty conservative timeline. This timeline, as you can imagine, tends to go more smoothly if you're able to bring to bear prior tools and templates from previous experiences. And let's keep in mind that this timeline is only for an FQHC Look-Alike strategy. So the timeline to partner with an existing FQHC, as we mentioned in one of the first slides, to just add on as a site through a change in scope could be shorter. But other considerations for that route include the alignment work necessary for that partnership to succeed. And with that, I'll hand it to Alan to summarize our key takeaways.
Thank you so much, Sarin and Elizabeth and Andy. So bottom line is this. We're in a situation right now, just to paint the picture for you all, right? We're having this massive increase in Medicaid, uninsured, and subsidized exchange. So people who were previously in employer-sponsored insurance, they're coming into Medicaid, many for the first time. Many people it's the first time in their family. They're not familiar with what to do. They're not familiar with what an FQHC is or how to navigate care. They're certainly not going to help you as a health system or IPA understand whether they need to go to an FQHC or how that would help you financially. So you've got these patients who really, it's new for them. And they're by the way, they're expecting the same level of care. They've been commercial, they've been used to commercial. And so they really are going to have expectations, as Elizabeth was saying, commercial level expectations. So this whole new group of folks coming into Medicaid and uninsured. At the same time, we've got folks who've been putting off care now for months. And they're probably going to continue putting off care for the next month or two. And then we'll start to see people over the next, say, 2 to 3 to 4 to 6 months start to come back in a wave of folks who've been chronically ill and haven't managed well, folks who've put off surgery. This morning, I was talking to one of our clients in LA that does capitated oncology, and they were talking about how their fee-for-service visits are non-existent right now, and their doctors are all surviving on their capitated rates. So guess what? What's happening to all those people who are supposed to have infusion and surgery for cancer? So we're in this really interesting situation now where Medicaid and uninsured are increasing. Visits and care are about to go up exponentially. We're all learning how to use telehealth. And so the reason we wanted to have this conversation with you all and share the thinking about having FQHCs be part of your strategy is that we've always felt this was important in the first place. You want to improve access to high quality primary care and specialty care. Well, you want to make sure that folks who are Medicaid also have access to high quality specialty care. And so we wanted folks to begin to start to think about how to use some of the strategies that Andy and Elizabeth and Sarin have talked about today to be able to engage either with community FQHCs or create your own FQHC lookalikes, or partner with a community FQ to potentially add one of your clinics as an FQ site, and really integrate the care model. Really start to think about how your specialists can be either on-site or engaged in telemedicine, co-managing with those primary care doctors and advanced practitioners at the FQHCs, how the FQHCs can be integrated into your care management and care transition models coming out of the ER. We've had some of our hospital clients put FQHC sites inside the hospital next to the ER. We've had very successful partnerships whereby the FQHCs are contracted in the IPA and actually capitated for primary care, sometimes for specialty care services as well. Another benefit is these FQHCs, the ones in the community, and as you take clinics, and Sarin spent a bit of time on this, you think about clinics that are best fit to transition to become an FQHC lookalike, or you're partnering with a community FQHC to, again, add one of your clinics onto their FQHC. FQHCs are well set up to integrate community-based organizations. What does that really mean? Food, people who are hungry, people who need shelter and housing, people who need legal aid. Guess what? After the COVID epidemic, there's a huge need for these things, right? You have people who are going to be thrown out of their apartments and their other rental homes in record numbers. You're going to have people with immigration issues still continuing. You're going to have people with food insecurity issues, which is a massive problem nationally right now. How do you integrate the food pantries? How do you involve the Legal Aid Society folks? These are folks that are used to working with FQHCs, and FQHCs are used to working with them. So if you don't already have a strategy, or even if you do, bringing the FQHCs to bear to help to organize these community-based organizations can be hugely helpful. You know, we have clients, health plan clients now that are working with IPAs and health systems to actually create fee-for-service contracted CBO networks that are going to be integrated and aligned with the FQHCs and the providers. So a very exciting time for that, and the FQs are a key part of that. We talked about aligning financial incentives. There is a benefit, of course, from the FQHC side. Getting that wrap rate is really useful and helpful to pay for some of these extra services Medicaid patients need. What's also important, and this was mentioned earlier in the PowerPoint, it's important to have a contracting strategy with the health plans. There are ways to really maximize the dollars while aligning incentives around things like quality, around things like MLR shared savings, so that you still get that PPS wrap rate helping you financially while you're really working to align folks around the right quality incentives and maximize the dollars for those quality incentives. It's a win-win situation for the health system, the IPA, the FQHC, and the health plans. There are additional funding streams. So we're in the middle of COVID. You know, we feel like we're talking about COVID all the time, but it's a good example. FQHCs are often in line for special funding streams that other folks aren't, which is another reason to have an FQHC strategy, because you're not going to be sitting at that table if you're not engaged with FQHCs, having an FQHC strategy so that you're partnering with folks from the beginning. And then finally, I talked a bit about the care model, having that improved care management for Medicaid and also dual eligibles, which is another rising challenge in our country. It's a great opportunity to bring that care model to bear. And we'll do, we have a few minutes left for some Q&A. I'm going to ask Sarin, if you don't mind, Sarin, fielding one of the questions. One of the questions is, do look-alike clinics, so in other words, if I as a health system take one of my clinics and I want to make it a look-alike FQHC, are there special facility structural requirements similar to traditional FQHC in the community?
Yes, it's very similar. So we look to see if the clinic is closed off by 4 walls. And during our assessments, we typically come on site and we check to see if, for example, the medication is all locked up, there's a sink, there's a bathroom accessible, there's a waiting room area, et cetera. And so it's very similar. It's not exactly the same. We also take a look at the floor plans just to make sure that, for example, the fire safety routes are all outlined in addition to where or how many doors there are. And so, yes.
Great. Thank you so much, Sarin. Elizabeth, a question for you came across, and the question is, what are some of the analytics and some of the key considerations that should be examined, both internally and within the market, if you're trying to determine what FQHC to partner with to potentially have them come in and take on one of your sites?
Yeah, definitely. So FQHCs have reporting through UDS annually, that they have to report their quality scores, their patients that they see, their including the number of uninsured patients that they saw. And so a good place to start with analytics is to looking at the previous UDS data for that FQ population, or for that FQHC that you're looking at in the population that they're serving. Within those analytics, not only can you see their quality metrics, the hypertensives that they have controlled, you can also take a look at the new patients versus engaged patients that they have. And so this is something good to look at as far as, how many new patients are they bringing in per year right now or prior to COVID, and how many patients are they continuing in their care or retaining. And so that's going to, be something that you want to take a look at as far as the services that they have up and implemented that is retaining their patients in care versus just a continual kind of, mill or, kind of in and out of all the patients. And so something to think about when you're looking at what FQ to partner with. I think starting with the UDS just in terms of quality of care and patient population is a great place to start, and one of the most important you're going to want to look at, period. I think the other things that you want to look at are some of what Dr. Snyder had referenced around the teaching facilities. And so, thinking about your FQs that have already embedded some of these teaching facilities or partnered with other organizations to embed the teaching facilities, the GME programs, there's a huge amount of regulation that comes with having a GME program within your FQ. And so knowing that they have had to go through that and continue with that is going to speak to the rigor that they've already been operating with and under. And so another something to really take a look at and dig in as you're starting to think about who to partner with. Another thing to look at is the services that they're providing. And so earlier when I was speaking to, thinking about embedding your specialists or, partnering with the FQ, look at what services they don't have that you can offer a significant value with. And thinking about their current patient population, their mix, or what they might be missing right now. And so that's also something you want to take a look at to see, okay, where is this partnership really going to create benefit that the FQ is going to be excited for us to come to them, but also it's going to allow you to embed the specialist there and potentially have this, additional services as far as bringing in more primary care patients as well as having your specialist patients with a medical home. And so thinking about the services strategically there so that there's not competition, but collaboration and really serving a greater need in the community. And those are some of the things I would start with as you're starting to kind of dig into who would be good FQs to partner with.
Thank you so much, Elizabeth. And Andy, a question for you on specialty care and how to negotiate. Could you talk a bit about how that rate structure is developed and the ability to be successful negotiating for something like a % of a PPS rate for specialists?
Well, I can try. It's having played through this a few times before, it's challenging, right? So you want to hire, let's just start at the granular level. You want to hire a cardiologist and put them into the FQ, and you try and negotiate a rate for their visits, and you realize it doesn't add up. You can't quite cover their salary plus benefits, et cetera. So now you're stuck. And even though it's better than seeing the Medicaid patient in your own office rate, you're still not getting enough of the PPS rate, perhaps, to make you consider yourself whole, whatever that may be. I think that's the common scenario. And I think what's missing is that the people trying to do that, let's say a cardiologist or department or so, also don't have the greater perspective and the financial wherewithal behind them to put the business plan together, because you could take a $20 loss per visit if you're going to get 10% of those visits converted to an inpatient procedure of some type. But the problem then occurs is that someone else is doing that procedure and getting credit for that. So how do you then make the person actually at the FQHC not get penalized? So I think those are the dynamics at play that you have to work through to case by case. But that's tier one. The second tier is to keep in mind it's also a bigger picture than that. If you're structuring a relationship with the FQHC, a rate per visit for a doc is not the be and end all, and you have to, move monies around. And that's just the way we've always worked in healthcare, and nothing's new here either.
Andy, thank you so much, and thank you everyone. We're right at the hour, so I'll thank all of our speakers and those of you who joined. We got many more questions than we were able to answer, so feel free to submit more via email. We will put together a Q&A sheet and get all of your questions answered and out to you. As we talked about earlier, we will also send you a PDF of the deck and a tape of the webinar. So everyone, please stay safe. We hope you all get time with your families amidst the busyness trying to care for your communities. We appreciate your passion and your mission-driven commitment to your communities, and we hope to talk to you all soon. This is CoPal Solutions signing off. Thank you.